Hi, Pradeep. Pradeep, are you there? Pradeep, are you there? Pradeep, are you there?
Madam, very good evening. Hope I'm audible, madam.
Yeah, Pradeep.
Yeah.
Pradeep, now
Okay.
whom should I make co-host, you or?
Host, I mean, you can make Sendil. Sendil is there already. Sendil, good evening, Sendil.
Yeah, good evening, Pradeep.
Good evening. Sendil is there. Is my our colleague, ma'am. And also
Okay.
Dr. Sana will be joining. So better, I think you can make Sendil as a host.
Senthil as host.
Yeah.
I'll be the host. I'll make Mr. Senthil the co-host.
Okay.
Okay.
Yeah.
And Pradeep, you have all the this one, right? CVs and all.
Yeah, I got it, madam. Got it.
You got it, right?
Yeah,
Okay.
got it.
Yeah. It's all ready.
It's ready. It's ready.
Okay.
Only thing, Dr. Sana has to join.
Okay.
Sendil, I mean, Sendil, you got the revised short CV, na? The new one. Sendil?
Yes, Pradeep, you have mailed it.
Yeah, got it right now.
Ms. Senthil, keep everything on your desktop itself, so that the minute they ask you to show the CVs, you can show it.
Okay, I hope that Dr. Sana will be sharing that CV.
Okay, she will share the CV.
Am I right, Pradeep?
Yes, Sendil, she will be doing it. Yes, Sendil, she will be doing it.
So you have the understanding, right? There's no confusion.
Yeah. We already have discussed, madam.
Okay, then fine. I will not interrupt at all.
Only thing, I mean, the slide deck is with us, but in case doctor wants to do it themselves, they can do it, right, madam, from their end?
Yeah.
Okay.
However, they are comfortable.
Yes. Dr. Sana, very good evening. Hope I'm audible.
Yes, sir. Good evening. You're audible.
Very good evening. Thanks for joining, madam. Thanks for joining. And along with us, we have Deepa Madam from Clinic Tech, and of course, Sindhil is there with us.
Hello, Dr. Sana.
Hello, ma'am. Hello. Good evening.
Good evening, Dr. Sana.
Hello. Good evening, Senthil sir. Good evening to all.
Madam, the second one, I think it should be fine, right? Along with the brand of Clinic Tech. The first one, which
Oh, yes, sir. Yes, I have received it with the logo.
yeah,
There's no here.
yes,
So at the beginning, when the session starts, I'm supposed to share that.
yeah, exactly. Then
Okay, sir. I'll share the screen at that time.
I mean, what we can do is we can first introduce Dr. Krishna sir, then we can ask him to take it forward.
Yes, sir. Okay.
By any chance, you have the minute they log in, the audience login, what screen are they going to see? Do you have anything welcome or anything like that?
We don't know, but what we can do is we can display the agenda. I mean, the first slide.
Or you can display the agenda flyer,
Agenda.
whatever we have, no?
Yes.
With all the doctors' photos and all.
Oh, yes, ma'am. I will display that.
Yeah, I
Shall I
think.
share my screen?
Yeah, or what we can do, madam, you can display the first one, women's health update. I'll be fine. Then we can go.
Yeah, that'll be fine. That'll also be fine.
Yeah.
Maybe we'll start at 5:55. Can we start sharing that screen?
Yeah, ma'am. I will share that.
Yeah.
I will share.
So maybe in another 5 minutes, 5-10 minutes time.
Madam, to check, I mean, we are in live, right?
Not yet.
Not yet, right? Okay.
No. Yeah. We are live actually.
Yeah, okay.
We are live.
So very good evening, sir. Very good evening, sir. Pradeep here, sir.
Hello. Yeah.
Hello, sir.
Hi, Deepa.
Dr. Sana is here also, sir. Our medical advisor.
Deepa, can you get permission from Pradeep and put a debate slide in here? That Pradeep, it's okay if we can put a slide for debate.
It's absolutely fine, sir. Absolutely fine. That's my issue, also.
Deepa, will you do that?
Which slide should we put, sir?
You can play this thing somewhere after one or two talks, or you can just put a slide with debate and how to register.
The video we can play, no, sir?
Ask for that, Pradeep's permission.
Sir, this is in our program, sir. So absolutely, if you're fine, there's no issue. Of course, we're using the Clinic Tech, sir. Thanks.
Right. Okay. So use that, no?
What time should I play that video?
Maybe between one talk and the other. Or...
Okay.
Best is to make one slide also. Make one PowerPoint slide. We debate both virtual and physical. And primercme.com. Okay, whichever.
Okay.
Whenever we can start, you let me know. Huh?
Okay.
Hi, Krishna.
Hi, Jayashree. Hear me?
Yeah. How are you?
Going on. Big meeting ahead. So,
Yeah. I was going to say all set. Huh?
We have already physical 750 registrations
Brilliant.
and online more than 11. But I know that I'll send you the link. Monday to Friday, 7 to 9.
Yeah, I saw that. That's online, isn't it?
Speakers, yes. Domenico at Chile is speaking, and that's like big. Then we have this lady who did work on intermittent fasting. In first human study, Pamela Taub, Pam Taub. She's actually Pramila Rajendran Taub, but she's speaking some really good stuff on weekdays.
Very nice.
Please, I'll send you the faculty link. Just log in. It'll be fun, and we can do questions. Lots.
So the Saturday Sunday meeting is also physical with streaming, or that's purely physical?
It's physical, and I'm cutting off Chennai from the stream.
Why?
Now the people show up for 1-2 hours or show up for lunch and then go home. So just to break this habit of, we have to retrain everyone to come back to a meeting, right?
I think it's good if people stay home. It'll reduce the global warming. I think it's okay to come out once a year or twice a year for a big meeting. The therapy is anyway.
You're a homebody, Jayashree. Now,
absolutely.
I would like just waiting for a time when I can just go back.
I'm sure you're already traveling.
I am.
By what I think is crazy standards. So
I used to live off a
How's your daughter?
She now 12th standard படிச்சிட்டு
அடுத்த மாசம் exam இல்ல no April
April
yeah?
26th exam. Hopefully Bapu can check. Hopefully she's off my hands.
I don't think that ever happens, Krishna. That's what you think.
It's the other way around. We are at my hands, isn't it?
Different challenges at each stage.
I know. Don't remind me. I'm thinking of at least வந்து படிக்கிறதுக்கு கூட உட்கார வேண்டாம்.
அது சரி, அது ஒரு பெரிய ரிலீஃப்.
நான் காலையில 4:30 மணிக்கு எழுந்து காஃபி போட்டு குடிச்சேன். Doesn't hurt me much. It's a time that I get up, but வந்து எழுப்பி காஃபி போட்டு கொடுத்து படின்னு சொல்லிட்டு. It's a nice.
How's your mom?
Mom's okay. She needs a cataract, but otherwise she's hanging in there. But it's nice to be able, at least on the. Hopefully, last time when the meeting, ours was the last physical meeting that ever happened in the country.
And the debate last time.
Just the numbers were climbing.
I know. Yeah.
This time it's hopefully we have everyone around. Come to the faculty dinner, it'll be nice.
That's on Saturday, yeah?
Saturday, 7:30. Illame Taj done. It's not like it's far away. That's why we sort of place it centrally.
Normally you have it in either like ITC or that other one. What is that
Meridian.
one? Santo.
No, Meridian. We don't do the Leela's.
Leela,
See, முடிஞ்ச வரைக்கும் I try to avoid. It's too upscale-ish in the sense that sense of not sure, but ultimately we'll have to end up doing it simply because of the numbers. Before the last year, we were clocking 1,500 people at a time, meaning about 800, 900 in the hall at any time. Adanala, it's time to move up. No, 1 minute. We can start on time, Pradeep?
Yes, sir. We can start, sir. I think we'll wait for Dr. Anjali Madam also. Then also, I'm checking with Ravi, sir, how many delegates has joined. So I think we'll start in 5 minutes, sir. That'll be nice.
Start on time.
Yeah. Okay, sir.
Please.
Yes.
By the time the introductions are done, I'm going to do a hum and haw about prolactin for a few minutes, so don't worry.
Sir, we will start exactly in 5 minutes, sir. 6:05 will start, sir.
Mhm. Dr. Sana will take the questions, right?
Yes, sir. She will be taking, sir, questions. Yes.
Salubia. I think Anjali is also joined in.
Hey, good evening.
Hi, Anjali. Welcome.
Hi, Jayshree.
Hi, Anjali. How are you?
Good, thank you.
Sana, ready?
Sir, she's ready. Just give me a moment, sir. I think she has some problem with the laptop. She cannot unmute herself.
I am known to make people speechless, but this is.
Hello. Good evening, sir. Good evening, ma'am. Good evening to all.
Hi, Sana. How are you? Why don't you start?
Uh, Sir, there were some technical issues. I'm not able to use the mic while sharing the screen.
Why don't Pradeep? Why don't you send them? Why don't you share the thing?
Madam, sir, I'm doing it, sir. I'm doing it right now.
Deepa, you need to give permissions to people to share the screen, right?
Sir, I've made co-host to Dr. Sana and Dr. Senthil and all, Mr. Senthil and all.
Okay.
They can share.
But you have to make me, Jayashree and Satya also, because we have to share.
So you don't have to be co-host for all that.
Okay.
You can share.
Wait, shall I try sharing my screen?
Yeah.
Can you see it?
Yes, sir. Go to the slide mode, sir. We can.
Yeah, that's fine.
Sir, Senthil is doing it right away. Just he's doing it, sir.
It's working. If you're on a phone, then it has issues. Okay, let's go.
Yes, sir. We'll start the session now. Okay. Good evening, everybody. A very warm welcome to all the speakers and the participants who have joined us today to discuss Women's Health Update 2022. Women's Day is celebrated internationally on 8th March. But it doesn't mean that we cannot discuss women's health on any other day, as I'm sure everyone agrees that we need to discuss women's health as a priority on every day of the year. This occasion, we do mention women's health because we want to emphasize the role that women play in society, and also maybe a fact that women's health needs to be given utmost priority. Today, we have a distinguished gathering of doctors who will be our speakers for today. I would like to give a brief introduction for Dr. for our three speakers. The first speaker for today is Dr. Krishna G. Sheshadri sir. Sir is a renowned endocrinologist based in Chennai. Currently, sir is practicing as a senior consultant and director, Chennai Diabetes and Endocrine Clinic at Chennai. He's also senior consultant endocrinologist practicing at Apollo Hospital. He is the director of Primer, a medical education company, and PMS PAMS, a not-for-profit medical organization. The topic on which Sir will be speaking today is approaching hyperprolactinemia. Hyperprolactinemia is an entity that comprises all conditions which have the common feature of elevated prolactin levels. It could be due to various causes, which will determine the subsequent management or the approach. Certain conditions like pregnancy also necessitate the requirement of a different approach. Hyperprolactinemia has a multifactorial etiology, and presentation also could be misleading. The topic will be discussed by Sir in detail. Any doubts regarding this, please type in the chat box. All the questions will be taken at the end of all the 3 talks. I hand over to you, Krishna Seshadri sir. You may begin the session.
Please stop sharing. Yeah, thanks. Am I audible and visible? The slides are visible, right?
Yes, sir. Yes.
Thank you. So I thought I'll take a small detour today, simply because a lot of times we do prolactin talks, but not in the context specifically of of understanding its deeper import, especially in infertility and others. So before we do the approach, I'm going to take a quick detour and look at the evolutionary physiology of prolactin, because it's really fun. While we know that it's secreted by the pituitary, but it's also secreted by the breast itself and the placenta and uterus. Many of us are probably surprised to know it's actually secreted by T lymphocytes. It's a cytokine. In many ways, it's a cytokine. It's right up there in the immune response, and as we know that it actually is very important in this particular instance in terms of preventing problems during implantation. Run through this very quickly. Won't spend a lot of time in detail, but just to give the flavor of understanding this wonderful hormone. It's a very evolutionary, very old hormone that is involved in many things, especially in birds. If you look at it, is involved in osmoregulation, metabolism, reproduction, in metamorphosis, and migratory behavior in birds is very much dependent on prolactin. And of course, it's important for maternal behavior, not just lactation. In humans, it's evolved to a point where it's involved in these 3, but I suspect that it's also involved to some degree in immunity. Very interestingly, 400 million years ago, we had a common gene for prolactin and growth hormone, and that's why pituitary tumors such as acromegaly still secrete prolactin. So the 3 of these, erythropoietin, prolactin, and growth hormone, share a common ancestor. And at some point of time, first erythropoietin left. Growth hormone and prolactin are still together in cows, somatomamotropin, but in humans, these are 2 distinct hormones. The other interesting thing is that the hormone that we see as prolactin in pregnancy is akin to human placental lactogen, and it's actually it's actually more similar to growth hormone than prolactin. The pituitary prolactin itself is coded in chromosome number 6. Right? We know a lot about human prolactin from the work that we've done with rat prolactin, but what is interesting is the kind of control that is there. We know about thyroxine and TRH, but other things control prolactin. For example, serotonin, opioids, angiotensin, calcitonin, neuropeptide Y, bunch of these. If you knock out prolactin, at least in rats, you will find that there is irregular estrous cycles with no luteal phase. So this luteal phase function is still present. In the breast, there is ductal proliferation with no lobulation. And of course, there is no implantation with prolactin is knocked out. If you knock out the prolactin in the corpus luteum, then there is no vascularization. There's a lot of apoptosis, right? There's loss of progesterone function. So clearly, at least in the animal, prolactin is very important for corpus luteal and especially progesterone-based function. So how does prolactin work? It potentiates the steroidogenic effect of utilizing hormone in the granulosa luteal cells. And there it inhibits this particular steroid called 20-alpha hydroxy steroid dehydrogenase, which inactivates progesterone. And it promotes luteal hypertrophy and progesterone synthesis. In some cases, it can be luteoliticosis. Somewhat different from rat and humans, we do not have a mid-estrous peak of prolactin. It is flat throughout the menstrual cycle. But The human ovary makes prolactin. It is very, very high in the premenopausal ovary. It is found in the follicular fluid. And these follicular fluid prolactin levels correlate with successful IVF. It is anti-apoptotic in granulosa cells and may actually have a paracrine role, just like PTH, which has a paracrine role, PTH-RP, which has a paracrine role, vitamin D, which has a paracrine role. Prolactin can have a paracrine role. In pregnancy, of course, the prolactin goes up, but if you notice this very carefully, humans have evolved other prolactins. There is, if you look at the amniotic fluid prolactin level, look at the way it peaks, and clearly that's not just due to maternal prolactin. So the prolactin levels in pregnancy that go up, which pretty much are high by 20 weeks and then keep going up through pregnancy, is mainly by the placental lactogen. It's a very, very important hormone in the fetus. So prolactin levels start rising at 6 to 8 weeks of gestation, then increase to about 200, 300 at term. And concurrently, there is lactotroph proliferation, probably due to estrogen. And prolactin begins to rise in the fetal circulation at 20 to 24 weeks. And it increases steeply from week 30 to term, when it reaches levels similar to maternal serum fluid. Right? Unique to humans, the decidua produces very large amounts of prolactin, which accumulates in the amniotic fluids, and there it can be as high as 4,000 to 5,000, and it reduces at term. It is present in the deciduum, where it has a lot of functions, and of course, the amniotic fluid prolactin is involved in other things. For example, osmotic regulation, electrolyte transport, causes formation of polyhydramnios, important in fetal lung development. Can also cause complications of gestation diabetes. Postpartum, the first 7 days, you see that neat suckling reflex creates a milk reflex, and then it continues, but it was very erratic after that, between 10 and 40 days. Beyond 80 days, suckling often does not cause a prolactin reflex. So pretty much by 80 days, your prolactin should be completely normal in a woman who's delivered a child. Interestingly, it's involved in reproductive behavior. We don't know too much about it in humans, but it can cause things like pseudocyesis, which is well known. And it's also involved in both male and female orgasm. So one of the important things is sometimes when you check fasting prolactin levels and they're elevated, it could be because of sexual activity in the past 24 hours. And that's one of the reasons we actually ask that question and ask people to repeat it. Right, so I won't spend too much time on this, but remember that prolactin is one of those very hormones that is positively self-regulated and it is negatively regulated by dopamine on a feed-forward mechanism. It's positively, so when you take away the dopamine inhibition, you have a lot of prolactin that is being produced. In addition, TRH, vasoactive intestinal polypeptide, oxytocin, a whole bunch of these, including kisspeptin, have some effects. Estrogen does not have a direct effect on prolactin, although it maintains its effects through galanin. But remember, oral contraceptives are an important cause of mild hyperprolactinemia. What we are learning more and more is like other things that are controlled by the hypothalamus, whether it is light, odor, sound, or stress. Each of these may actually have an effect on prolactin. I won't spend time on prolactin action. We'll move on to look at hyperprolactinemia and its consequences. What can it do? Amenorrhea and ovulation, reduced libido, and orgasmic dysfunction in women are consequences of hyperprolactinemia. It can inhibit the GnRH production or pulsatility. It increases dopaminergic tone. And these present as 3 things. One is galactorrhea, second is hypogonadism, and third is infertility. Galactorrhea may be present in about 5 to 10% of normally menstruating women. Of these, up to 27.9% have elevated prolactin. Remember that the volume of milk does not correlate with the prolactin levels. In patients who present with galactorrhea, amenorrhea, or oligomenorrhea, 84% have hyperprolactinemia. Remember that galactorrhea Normoprolactinemic galactorrhea does not require treatment, just reassurance, especially in women. What this statistic does not tell you is also that if you've had 1 or 2 children, then even up to 15% can have expressible galactorrhea. The way to look at how menstrual dysfunction occurs is by stopping the dopaminergic agent given to hyperprolactinemia and see what happens. One is, the first thing that happens is the luteal phase shortens. And then at some point of time, an ovulation occurs, and then amenorrhea is the other extreme of what happens in menstrual dysfunction. The shortening of the luteal phase is associated with subnormal progesterone levels. It need not be a measurable subnormality in progesterone levels. It's probably more local. So what happens then in men, especially, it presents only as hypogonadism, but even in women, there are changes that cause hypogonadism. For example, the first thing that happens is alteration of GnRH pulses, right? And then an interference with gonadotropin action. And of course, there's an inhibition of 5-alpha reductase that also occurs. There is also an interference with the steroid feedback. So these cause hypogonadism. Infertility is a third presentation. In one series of 367 women with infertility, very old Mark Molitz's data had hyperprolactinemia. You don't see this much amount today. In 113 women with infertility, 5 of 22 hyperprolactinic women had neither amenorrhea nor galactorrhea. But dopaminergic action agonists restore the fertility. Remember that many of these women can have transient hyperprolactinemia that is also responsible to a dopamine agonist. When you see hyperprolactinemia and infertility, the recommendation is to treat it. So what causes it? Remember that one, you can have a tumor that makes prolactin. That's a simple cause of it. Second, this tumor need not be a hyperprolactin. I mean, a prolactinoma, it can be an acromegaly or a growth hormone producing tumor in which prolactin can be co-secreted. I told you that these are cousins from many, many millions of years ago, right? The third, if you look at the right upper hand corner of your screen, you will notice that in patients with hypothyroidism, there's a lot of TRH. And TRH is a direct stimulator of prolactin, and levoprolactin increases. Do not treat hyperprolactinemia. If your TSH is high, treat the hypothyroidism. And it may take up to 4 to 6 months for the prolactin to normalize in some patients with hypothyroidism. So patience is a virtue. Patience has always been the friend of the endocrinologist. It is even more so here. And of course, if there can be a tumor or any other reason where dopamine is cut off, and when dopamine is cut off, prolactin increases. So these are the causes of dopamine inhibition, anywhere from craniopharyngiomas, dysgerminomas, pituitary, non-secreting pituitary, adenomas, a whole bunch. Interesting stuff like sarcoidosis, empty cellular syndrome. My favorite is lymphocytic hyperphysitis, and of course, anything that cuts at stalk can cause hyperprolactinemia. The most common cause, of course, in practice, and the most common reason that I end up seeing patients with hyperprolactinemia are medications. Anything with psychoactive medications. One of the commonest causes, the most common cause in my practice is PAN-D, the combination of antiprazole with the antiemetic that is present. And that really is the reason why I get to make some consultative fees. So how do you approach hyperprolactinemia? The first thing, of course, is to exclude pregnancy medications. Take a detailed medication history. Ask people, what did you take? Were you on any medications? Sometimes, for example, that's the story of the PAN-D, they would have stopped it 3 days before, and then the prolactin would still be elevated. So exclude pregnancy, medications, wait for a good month, beat the prolactin. A lot of people recommend pooled samples. I don't do it in practice simply because if I see a really good, well-elevated prolactin, I don't do it otherwise. Pooled samples work. Renal dysfunction is one of the reasons, because prolactin does not get excreted in patients who do not have, who have an increased EGFR. The first step is to exclude hypothyroidism. If the TSH is elevated, treat the hypothyroidism. If the TSH is normal, get an MRI of the cellular. Now remember, if the prolactin and if you have very high prolactins but no symptoms, there are other options. We will talk about it in a moment. Generally, the MRI don't do cone views of the pituitary, don't do CT scans. The most cost-effective way to practice medicine is to do the most appropriate things first. If you have a tumor and this is less than 10 millimeters, remember 1.5 Tesla pituitary scans generally, overread tumors that are less than 3 millimeters, but anything more than 3 millimeters, it is a tumor. If it's less than 10 millimeters, it's a microprolactinoma. If it's no tumor, it's idiopathic. If a tumor is more than 10 millimeters, it's a macroprolactinoma. We'll talk about it. But sometimes you don't find a tumor, you have hyperprolactins, but the patient does not have symptoms. This could be a cause of this. This is called macroprolactin. Remember, prolactin is secreted. When it gets secreted, it has other forms of it. It can form aggregates. It can have post-translational modifications. There are big prolactins and there are big prolactins, but none of these are biologically active. So when you think of it, when you see a discrepancy between the clinical features, which are non-existent, but the prolactin level is elevated, ask the lab to do what is called monomeric prolactin or to measure the macroprolactin. What they do is they do a process called pegylation, by which the big prolactin is removed, and what remains is a monomeric prolactin, and that can be a good idea to see if it's a true hyperprolactinemia. Right? If you do have a true hyperprolactinemia, and it is either a microprolactinoma or there is no tumor, when should you treat? Not everyone requires treatment. Infertility is the most important reason to treat. If it's associated with amenorrhea, anovulatory cycles, luteal phase dysfunction, periovulatory hyperprolactinemia, even mild prolactin elevations in infertile women warrant therapy. The second, if there are signs and symptoms of androgen excess, if there's elevation in serum testosterone, free testosterone have all been reported. Prolactin may also have a stimulatory effect on adrenal androgen production, and therefore, dopamine agonist therapy results in normalization of serum androgens. One of the reasons that I consider important is headaches. A lot of times patients with microprolactinomas have headaches that is out of proportion to the size of the lesion. Remember, it could be 3 millimeters or 4 millimeters, but the patient will have intractable headaches. If the onset of headache coincides with the menstrual irregularity, a trial of dopamine agonist therapy is warranted. This is an autopsy study of looking at microprolactinomas. This is about 10,223 pituitaries, 11,135 of these were adenomas. It's 11%. 3% was macroadenomas, and the prolactin stain was positive in 45%. Even these were less than 15 millimeters. So lack of macroadenomas in the autopsy study suggested that growth from microadenomas to macroadenomas is a very uncommon event, right? And if left untreated, it's a very old study, but it's still very valid. There's about 139 patients, so the CT was used. It looked at the tumor growth was around 6.9%. The follow-up was 2.5 to 8 years. None of these people developed a macroadenoma or pituitary hyperfunction. Therefore, you reserve for medical therapy for patients with clear-cut enlargement. A doubling of the tumor is probably what you should look at. I use a volume-based calculation. If it's more than 50%, then you treat. In idiopathic hyperprolactinemia, that is that the prolactin is elevated, but there is no evidence of a tumor. 59 patients followed for 6 years. Only one patient developed a microadenoma, right? Again, treatment should be reserved for patients with symptoms or those who develop a tumor. Now, what else can happen with the hyperprolactinemia? If patients are amenorrheic or hypo or oligomenoric, then the mean serum estradiol levels are comparable to the earlier follicular phase estradiol levels. And there is also a lack of rise in the mid-follicular, ovulatory, and luteal serum estradiol levels. So these people are basically estrogen deficient, and they warrant therapy. This is looking at 52 hyperprolactinic women, mean follow-up of 1.8 years. Those with amenorrhea had a spinal to bone density of more than -1 ST. That really correlates with the 50 to 100% increase in fracture risk. And also, oligomenoric women had trabecular bone densities midway between the hyperprolactinemic amenorrheic women and the normal controls. The RR for developing osteoporosis in this particular study was 4.5. So somebody who's got hyperprolactinemia and symptoms, and especially oligomenorrhea, deserves treatment to prevent osteoporosis. So if they have amenorrhea, they have estrogen deficiency, they have risk for osteoporosis. They also need treatment, and also with postmenopausal therapy. If the estrogen is normal, no osteoporosis, no treatment is required. So to go on, if you've done the MRI, the tumor is less than less than 10 millimeters. Treat if there is menstrual dysfunction, infertility, headaches, and hyperandrogenism. Or treat if there is evidence of tumor growth. If the tumor is more than 10 millimeters, dopaminergic agonists are the treatment of choice. The way we need to look at macroadenomas is a prolactin more than 200 or less than 200. There is a definite correlation between the log of the basal prolactin and the size of the tumor. We have very high prolactin levels and the tumor is small, that's fine. But if you have a large tumor size, if the prolactin is low, we need to think of other things. One, normally the prolactin is more than 200, and if you have a large tumor, it's macroprolactin. The prolactin is 200, there can be several reasons. One is it may not be a macroprolactinoma. It need not be a prolactinoma, but a tumor that is cutting off the stalk. But more interestingly, there is a lab phenomenon we need to be aware of that is called the hook effect. Think of this as a container. And generally what we do when you do an assay is that the antibody is pasted to the bottom. The antibody to the C-terminal of the hormone is pasted on the bottom. And then the hormone is added, that is the serum is added to the particular container. The hormone attaches to the antibody. Then another fluorescent, or it depends on the assay, but usually a chemiluminescent tagged antibody is added to it. This attaches to the N-terminal and forms what is called a sandwich. This is what we call a sandwich assay. Then the supernatant fluid is discarded and the hormone is measured. And this is how we get hormonal measurements, by any of the CLIA or the chemiluminescent or the radioimmunoassays. Now, sometimes in a large prolactinoma, what happens is there is so much amount of hormone that some of this is not stuck to the bottom and it remains free. So you add the fluorescent tag N-terminal and then you throw it off, all the tag goes away and you just have a falsely low measurement because the excess hormone is discarded. How do you take care of it? You actually dilute it. When you think about hook effect, when you see a large tumor and you see the prolactin being falsely low, call up the lab and ask them to dilute the sample. Usually 1 in 100 should suffice, and that will give you the correct value. If it's a hook effect, it will give you a tumor in 2000s. Generally, I do not allow labs to give me values such as greater than 200 or greater than 300. I tell them to progressively dilute them till we get a fixed number, because that allows us to quantitate the patient when medication is. The other, if it's not a hook effect, then it is dopamine inhibition by a tumor that is cutting off the stalk and not necessarily a prolactin. Right? So to summarize, a tumor is more than 200. If it's greater than 200, then prolactin is greater than 200, it's a macroprolactinoma. If it's less than 200, dilute the sample. The prolactin is elevated after dilution, it is a prolactinoma. If there is no elevation of prolactin, then it's a non-functioning adenoma. Macroprolactinomas also do other things. One of the things is that it actually moves up, and you can see this dumbbell shape that is assumed. It's cutting off the optic chiasm, which takes the signals from the eye, and this is called bitemporal hemianopia. It can do other things. It can go in. It can travel in all sorts of forms, including into the ethmoid sinus and come out of the nose. Not a pretty sight, but it happens. It can cause anterior pituitary hormone deficiency. And in microprolactinomas, it's so small that most of us don't even measure the other hormones. But if you have a tumor that's more than 10 millimeters, it can cause cortisol deficiency, it can cause growth hormone deficiency, it can cause thyroid deficiency, as well as gonadotropin deficiency. The gonadotropin deficiency can be a function of even microprolactinomas. How do you treat? These are the options: transphenol surgery, radiation, and dopamine agonists. The first two are almost never used. Although if you have a surgeon like Edward Laws in your institution and you have a microprolactinoma, then you could try transphenol surgery if it's not working to medications. We never use, very, very rare for us to use surgery for macroprolactinoma. We talk about radiation is something that we almost never use. Why? Because surgery, if you look at the long-term normalization of prolactin, it's only 58 with surgery in micros and only 25 with macros, and the recurrence almost 20%. And remember, there's a finite morbidity and mortality. Radiotherapy is even worse, 20 to 30% normalization, and the time it takes for you to normalize is 5 to 15 years, by which time the fertility of the patient is gone. And remember that radiation fries the brain. In addition to causing hypopituitarism, there can be a lot of cognitive dysfunction. On the other hand, bromocriptine and cabergoline can both cause normalization of prolactin, 80 to 90%. No response at 5 to 10% of both of these. A greater than 50% reduction in tumor size within the first 6 months in many patients with 40%. Intolerance in 5 to 10% with bromocriptine. These are the drugs that are available pretty much today. The first line of therapy is cabergoline and not bromocriptine, because cabergoline can be given once or twice a week, and it doesn't require and it doesn't cause the kind of side effects that bromocriptine used to. For those of us who practice with bromocriptine for many years, remember telling our patients to take it in the morning, lie down, having dizziness, using other methods of using it like vaginal bromocriptine. Pergolide and finagolide never fulfill their promise. This is a comparison of cabergoline and bromocriptine. Can you see in macroprolactinomas, the prolactin response is around 82%, in micro almost 92%. So clearly superior to bromocriptine. And in tumor shrinkage, they're pretty much the same. In microprolactinomas, especially cabergoline is superior to bromocriptine. Tumor disappearance again is much higher with cabergoline, right? And even importantly, macroprolactinomas, cabergoline, 99.5% tumor disappearance. So remember that even optic chiasmal impingement is no longer a indication for surgery. It never was since 1986. So how do? You start off and you maintain, start the patient on cabergoline and then tell them continue to take some form of contraception till you become, till the cycles normalize, because even though these are very safe in pregnancy, you just want to make sure that you have limited the exposure, and you stop it when the patient is pregnant. So the size of the adenoma decreases approximately the same degree of prolactin concentration. You can't see it until weeks or months, but it can continue to decrease for years. But patients have to get pregnant. The risk of tumor enlargement in pregnancy is very low. 1.3% for microadenomas, 23% for macroprolactinomas, even lower, I think, in our practices. And both of these are fairly safe in pregnancy, although we limit the use, right? So what do? If it's a microprolactinoma with an intracellular macro or an intracellular macroadenoma, stop when pregnant. We talked about prolactin levels in pregnancy. Don't use them to follow. Just ask the patient, do you have headache? Do you have any symptoms? And if that's present, then you can investigate. It's a macroprolactinoma. Stop when pregnant. Ask the patient for headaches and symptoms. If you know it's large, then getting monthly visual fields is a good way to follow this patient. If there's suspicion, you can get an MRI. Remember, MRIs are safe in pregnancy. Large prolactinomas or intracellular extension. Pre-pregnancy, think of debulking or using bromocriptine throughout pregnancy. There is some safety for cabergoline also. People use bromocriptine for habit. Again, headaches, visual symptoms, monthly visual fields. What happens when you withdraw? For most of microprolactinomas, we use it for 2 years, and then after the prolactin sort of normalizes, you could reduce the dose from, let's say, twice a week to once a week. And if it doesn't go up, you can follow the patient with annual MRIs. At the end of 2 years, you can actually try removing it. There is a risk of recurrence, as you can see in this. With macroprolactinomas, the best thing is to keep the patient on indefinitely, or at least till menopause, the therapy. So this is where I would stop, and I think I have taken a chunk of my 20 minutes, and very, very happy to discuss questions either now, or if we have to wait, we'll wait.
Yes, sir. I think we can now, if you wish, we could have the questions at the end, sir, so that we could proceed with the sessions. So we will now move ahead to the second topic for today, which will be taken by Dr. Jayashree Gopal ma'am. Ma'am, I will give a brief introduction for ma'am. Ma'am is a senior consultant endocrinologist. She is currently director of Diabetic Endo India in Chennai. Also, founder, trustee of Diabetes Endo India Foundation, preserving health across generations. She is a senior consultant endocrinologist and diabetologist practicing at Apollo Hospital, and also holds the distinction of being the Associate Dean for Teaching and Research at MV Diabetes Research Center, Royapuram, Chennai. The topic on which ma'am is speaking today is elevation of TSH in pregnancy, or we can say in other words, hypothyroidism during pregnancy. Pregnancy acts as a natural stress test for the thyroid gland, and thyroid dysfunction is possible even if it was normal earlier, or in a woman who already had been diagnosed as a hypothyroid patient. It is crucial to maintain optimum thyroid health during pregnancy, as it determines not only the maternal health but also the fetal development. All the aspects regarding TSH approach monitoring investigations and the guidelines will be discussed by ma'am. I hand over to you, ma'am. You may begin the session.
Thank you, Dr. Sana. Yeah, I'm going to be talking. I think you put it very correctly, Dr. Sana. I liked what you said, TSH elevation in pregnancy. I'm not going to be talking about whether a TSH elevation in pregnancy signifies hypothyroidism. I think that's a topic for another sort of day, but I'll be talking about what are the current recommendations when you see TSH elevation, and what is considered a normal range, and what do we consider as TSH elevation in pregnancy. I'd like to thank Abbott for inviting me here and putting me on a panel with two good friends and endocrinologists, and looking forward to the discussion at the end. This is somewhat of a hotly debated topic among endocrinologists. I don't want to confuse the issue too much here, but just talk a little bit about the guidelines and on what evidence these guidelines have been based. So, like Dr. Sana mentioned, pregnancy is a stress test for the thyroid, as it is for other things. For example, your risk for diabetes comes to the fore. Similarly, your tendency to develop a thyroid problem also comes to the fore during pregnancy. And this happens because of various factors, but predominantly because, at least in the first 3 months of pregnancy, the thyroid gland has to make more thyroid hormone, both for the mother and also for the baby. It's only after the first 3 to 4 months of pregnancy that the baby's own thyroid, the thyroid follicles, have started to work and secrete thyroid hormone. Related to this aspect of the mother needing to provide for the increased thyroid hormone to compensate for the excessive volume in the mother and also for the baby, there are several physiological changes that occur in the mother. And some of these changes include, for example, related to the increased estrogen in pregnancy, there is an increase in the thyroid binding globulin, which means that the total T4 and total T3 increases. So if we use total T4 as a measure in pregnancy, then the cutoff limit that is recommended as being in the normal is 1.5 times the upper limit of the normal non-pregnant range. Another aspect that sort of affects the thyroid function during pregnancy, the thyroid blood test during pregnancy, is the fact that the HCG is very similar to TSH. They have the very similar alpha unit. They only differ in what is called the beta subunit. And because of this, HCG actually works like TSH, which means that it actually increases the release of T3 and T4, which partly causes a drop in the TSH, particularly most evident at 3 months of pregnancy, around the 12th week. There is also increased peripheral metabolism of the thyroid hormone, which means that T3 and T4 levels actually tend to drop. And this sort of drop occurs all through pregnancy, though it remains within the normal range, though the normal range itself compensates. There is a little bit of a dip in the lower limit of the normal range, usually in pregnancy. There is also increased plasma volume. And like I said, a lot of these physiological changes is to compensate for the non-functioning fetal thyroid. And because of all of these factors, because of the non-functioning fetal thyroid, because of the increased plasma volume of the mother, there is an increased demand of T3 and T4 by about 25 to 30%. And this is the way I explain it to women. So normally during pregnancy, your gland has to work about 25% more to compensate for the pregnancy. And if your gland is mildly underactive to begin with, it may not be able to compensate for this increased requirement or this increased demand. And therefore, you're more likely to sort of bring to the fore subtle or subclinical thyroid disorders during pregnancy. And this is a graph which shows the relationship between the peak and the HCG around the 12th week, which corresponds with a dip in the TSH around the 12th week. And quite often we are referred patients who have low TSH. Usually the TSH drop is to the range of about, say, 0.1 or 0.2. It usually does not go into the 0.01 range, usually, though we do see women with a drop in the TSH even up to that range. Thereafter, once the HCG starts coming down, the TSH levels start going up again. And typically in the second and the third trimester, again, the mean or the median TSH is set at a higher value compared to the first trimester. If you look at what is the prevalence of hypothyroidism in pregnancy, I think a better term for it, what is the prevalence of an elevated TSH suggesting hypothyroidism in pregnancy? If you use a higher TSH cutoff of 4.5, then these numbers vary from 10 to 15%, still very high, meaning 1 in about every 10 to 15 pregnant women would have an elevated TSH above 4.5. And the numbers are fairly steady across the 3 trimesters. If you use a lower TSH cutoff, 2.5 to 3, then the numbers increase to about a third of all pregnant women, depending upon the study that we look at. So if you move on to screening for thyroid disorders in pregnancy, several studies have shown that case-based screening. So some countries, though less and less, still continue to recommend that not all pregnant women, they don't recommend universal screening for thyroid. In India, we do recommend it, and I think that's important. It is a test that picks up something that can be easily treated and definitely has value in reducing morbidity during pregnancy and improves fetal outcomes. Whereas countries that recommend case-based screening, so they say only screen for the thyroid based on certain parameters, like if there is a family history, if the woman herself has had a prior history of a thyroid, if it is an older woman. So they have certain cutoffs, but case-based screening can miss up to 50% of thyroid dysfunction during pregnancy. Therefore, universal screening is recommended by a lot more countries now compared to earlier, and universal screening at first contact, similar to how we recommend screening for diabetes at first contact. So as soon as the woman comes into first contact with medical care, it is recommended that her thyroid function also be screened. And again, there are some people who are still against universal screening or are unsure about screening. And this is a survey by members of the American Thyroid Association. But I think the vast majority do advocate universal screening. And it actually fulfills, I would say, pretty much all of the criteria for a beneficial and a cost-effective screening program. And the test itself is relatively cheap, and you do have good treatment available, which is just replacing with levothyroxine. And there are a lot of literature showing that the outcomes are beneficial if you treat particularly overt hypothyroidism. However, where the areas of uncertainty remain and where there is a lot of controversy is what do we do with borderline TSH values? And I'll be talking about what we mean by borderline TSH values and whether such borderline TSH values are normal for that woman or whether they are truly indicative of thyroid hypoactivity or thyroid dysfunction. That is where there is a lot of controversy. So if you look at the commonly quoted Indian Thyroid Society and the FOXY 2019 recommendations, of course, they do recommend for universal screening. So all pregnant women should be screened for thyroid dysfunction at the first antenatal visit, and they only recommend to measure a TSH level. I would say it's better that we measure both a TSH and a T4 level for reasons that I should explain in a minute. So what are the normal TSH reference ranges in pregnancy? Again, what the American Thyroid Association in 2017 recommended was that we use locally derived reference ranges. Now, the problem is if you take a country like India, the locally derived reference ranges are extremely variable across the country. Studies, older studies, particularly done from North India, show that the upper limit of normal for TSH and pregnancy, when we say upper limit of normal, 95% of women would have a TSH value of around 4.5 to 5. Even in Chennai, when we looked at our data, the 95th percentile or even the 97.5th percentile for the upper limit of TSH was around 4.5. So what is the upper limit? We do not know, but what is recommended currently by the Indian Thyroid Society is in the first trimester to set it at 2.5, in the second and third trimester to set it at 3. Meaning any value which is above this, particularly if it is combined with a drop in the free T4 below the lower limit of the pregnancy range is indicative of thyroid dysfunction. However, like I said, there is a lot of heterogeneity and because of the ethnic differences and geographical variations in populations. So while we keep saying there is need for a nationwide study, I think what is more important is that we become familiar with normal TSH ranges in both pregnancy and non-pregnancy in the local population, in a relatively homogeneous local population, so that we are able to interpret variations around this outside these normal ranges. But till then, we continue to use these normal ranges. So what is defined as hypothyroidism in pregnancy? This I've taken from the national guidelines from the Ministry of Health. National guidelines for screening for hypothyroidism during pregnancy. And again, they recommend similar lines. First trimester TSH range is 0.1 to 2.5. Second trimester is 0.2 to 3. Third trimester is 0.3 to 3. And how they define hypothyroidism, I put it in a tabular column so that there is no confusion. Any TSH which is about 2.5 to 3 with a free T4, which is below the lower limit of the normal range, is considered overt hypothyroidism. Or any TSH which is about 10 with any level of free T4. It may be within, it may be low. This is also considered as overt hypothyroidism. Now, to have something like this, where you have a TSH which is above 3, but a free T4 which is below normal, is extraordinarily rare. And for endocrinologists, if we see values like this, we start thinking more about pituitary causes, whereas this is more common. This definition of overt hypothyroidism is what we would be using commonly, a TSH about 10 and any level of free T4. The subclinical hypothyroidism, again, a bit of a controversial issue. So anytime the free T4 is within the normal range, with a TSH which is below 10, it comes under the category of subclinical hypothyroidism. So a TSH of 2.5 to 10 with a free T4 which is normal is considered subclinical hypothyroidism. Now, again, within this, I would, in clinical practice, I think most of us look at two categories of patients within this normal range. A TSH which is above 4 or even 4.5, associated with strong or high levels of thyroid antibodies, or a woman who's had, say, several missed abortions, particularly in the first trimester, so a bad obstetric history, or difficulty getting pregnant. So this would be a different type of a pregnancy scenario compared to someone who has a TSH between 2.5 to 4 with completely normal negative antibodies and absolutely no bad obstetric history. I think these are two different clinical scenarios, and we need to keep this in mind when we are trying to decide about treatment. So even though subclinical hypothyroidism is defined as 2.5 to 10, remember that within this, there would be two sort of subcategories. There are multiple complications of leaving hypothyroidism untreated, whether it is subclinical or overt hypothyroidism. There are complications of leaving it untreated. And these include maternal complications like preeclampsia predominantly. Very severe untreated hypothyroidism, of course, can lead to heart failure. It has also been shown to be associated with placental abnormalities leading to low birth weight infants, increased risk of postpartum hemorrhage. Fetal adverse outcomes noted have included cognitive impairment, neurological abnormalities, developmental abnormalities. Congenital hypothyroidism, not so much, unless the mother herself has some genetic cause for hypothyroidism, which can be passed on. It's very rare to see it in an autosomal dominant fashion. Neonatal complications include commonly hyperbilirubinemia and respiratory distress. Now, a lot of these complications are far more common with overt hypothyroidism. If you look at the actual numbers, so this was a study which was published from India about 10 years back, and you can see that the risk of all of these complications, including pregnancy-induced hypertension, gestational diabetes, interestingly, IUGR, intrauterine fetal demise, all of these are far more with overt hypothyroidism. Subclinical hypothyroidism as compared to the normals did show slightly higher chances of developing pregnancy-induced hypertension, but not so much for the others. We'll come to subclinical hypothyroidism in a minute, but absolutely no doubt that overt hypothyroidism, particularly if left untreated, is associated with significant maternal and fetal morbidity. So perinatal outcomes are also more in untreated overt hypothyroidism. So increased risk of cesarean section for fetal distress, overall cesarean rate, higher chance of having a low APGAR at 1 minute, and other neonatal complications are more in overt hypothyroidism. And this is where we see more problems related to the subclinical category. So the subclinical hypothyroidism, though it is not really significantly associated with adverse maternal outcomes apart from PIH, significant risk of fetal adverse outcomes, including increased risk of preterm delivery, cesarean for a fetal distress, and again, a low APGAR score and other neonatal complications. So subclinical hypothyroidism is also associated with significant morbidity, driving home the point that both overt and subclinical hypothyroidism, if picked up, should be treated. So moving on to subclinical hypothyroidism and pregnancy outcomes. Like I said, it is associated with things like pregnancy-induced hypertension. Other studies have also shown that subclinical hypothyroidism more likely to be complicated by placental abruption, preterm birth I had mentioned earlier. This was a meta-analysis published a few years back, which looked at, and some of them you can look at the ones where the number is significantly, the risk of pregnancy morbidity is increased. For example, pregnancy loss, placental abruption, and neonatal death. So all of this is significantly more in a subclinical hypothyroidism in pregnancy. Studies again have clearly shown, I don't want to go into great detail about this, but to show that subclinical hypothyroidism, particularly the subclinical hypothyroid. So again, remember that subclinical hypothyroidism, the definition used for that is also varied. For example, in this particular study, they used a TSH of 2.5 to 4 as a definition for subclinical hypothyroidism. And what they showed was that with a TSH of 2.5 to 4 with no TPO antibodies, there was no difference in outcome in preterm delivery if this group of women received levothyroxine. If the TSH was more than 4, even though the TPO antibodies were negative, if the TSH was more than 4, there was a significantly lower rate of preterm delivery, which is why I said even within the subclinical hypothyroid category of 2.5 to 10, use a 2.5 to 4 category, use a 4 to 10 category. Another systematic review and meta-analysis showed that in women with subclinical hypothyroidism or who were TPO antibody positive, levothyroxine therapy did reduce pregnancy loss and preterm birth. Again, unless you carefully tease out what definition of subclinical hypothyroidism we use, it can be easy to miss this, and to say that every TSH value which is above 2.5 may need to be treated. Sometimes it's a bit of a nuanced clinical decision making that we need to do in that situation. So how do we manage all overt hypothyroidism? So a TSH of more than 2.5 with a low free T4, I wanted to keep that in mind, or a TSH which is about 10, irrespective of the T4 needs to be treated. And of course, the target TSH, if they are already on levothyroxine, is to maintain the TSH below 2.5. And some guidelines recommend that we increase the levothyroxine dose by 30% as soon as pregnancy is diagnosed. I think it depends on if the woman can get a blood test done immediately and let you know the results. If they cannot get a blood test done within a few days, I think this is good advice. If they can get a blood test done within a few days, I think that's far more preferable, so that they tell you what is their current thyroid status and you can decide on the dosage. The thyroid TSH needs to be monitored every 4 to 6 weeks until mid-gestation and at least once near the 7th month, and thereafter probably once around the 9th month. If you move on to subclinical hypothyroidism, I'm just going to come back to my thing. So subclinical hypothyroidism, certainly TSH, which is greater than 10, but which comes under the overt hypothyroidism category. TSH between 4 to 10 with positive antibodies. I don't think there is any doubt in this group that they need to be started on treatment with levothyroxine. A TSH between 4 to 10, even if TPO antibodies are negative, you would certainly consider that you would need to start levothyroxine. TSH between 2.5 to 4 with strongly positive TPO antibodies, again, you would consider treatment. It is in the TSH category between 2.5 to 4 with no TPO antibody that there is a lot of confusion. And again, like I said, in that category, I would use clinical judgment to decide if they need to be on levothyroxine. Postpartum care, fairly standard. Immediately after delivery, she can go back to taking the pre-pregnancy dosage. TSH levels ideally checked 6 to 8 weeks after delivery. If it is a newly diagnosed hypothyroidism in pregnancy, they may not require levothyroxine in the postpartum period. You can either stop the levothyroxine immediately after delivery. I usually choose to keep them on levothyroxine for about 6 to 9 months, for as long as they are nursing their baby, because there are some thyroid fluctuations after delivery. So sometimes we stop. If they're on a very minimal dose, 25 mcg, 50 mcg, we stop it. Sometimes we choose to continue and stop it after 6 months to see if it was truly a pregnancy-induced hypothyroidism. And if they have evidence of thyroid autoimmunity, they are at higher risk of developing thyroid disorders later on in life. So make sure you check their TSH on an annual basis. What about the euthyroid pregnant women with thyroid autoimmunity? Now, this is another controversial area. So TSH is below normal, but strongly positive thyroid antibodies. What is the significance of thyroid autoimmunity during pregnancy, before conception and early pregnancy? This was a very, very good review that was published more than about 10 years now back, which looked at the effect of thyroid antibodies on various aspects of pregnancy, including fertility. And I think Dr. Anjali is going to be talking a lot about this in her talk, and neonatal outcome and maternal outcomes. And basically a lot of the outcomes showed an increased risk with the presence of thyroid antibodies, particularly preterm delivery risk. It also increased risk of unexplained subfertility, miscarriage, recurrent miscarriage. So these are women with normal thyroid function, as evidenced by a TSH which is below, say, 2.5 or 3, but with the presence of thyroid antibodies. Whether the antibodies are the cause, the presence of antibody is a general marker for some other reason for which they are more at risk for miscarriages, or whether the antibodies per se are causing the miscarriages is controversial topic. In general, the current consensus thinking is that the antibodies are just a marker for some other immunological dysfunction, which is causing an increased risk of abortions. And it is not that the antibodies per se are increasing the risk of abortions. If you look at, again, the effect of treatment with levothyroxine and thyroid autoimmunity and whether it helps in pregnancy, wildly varying studies. For example, this study looked at euthyroid TPO antibody positive women and showed that there was reduction in miscarriage and preterm delivery. This was published about 15 years ago. This study also showed positive outcomes. It showed that treatment with levothyroxine reduces the risk of preterm delivery. However, this large study, which was the most recent study published in 2019, looked at whether levothyroxine therapy could increase live birth rates among euthyroid women who had thyroid peroxidase antibodies and a history of miscarriage or infertility. And this study looked at almost 1,000 women. And what the result of this study was that the use of levothyroxine in euthyroid women with TPO antibodies did not result in a higher rate of live births than placebo. Again, the problem with a lot of these studies is, what do they use as a definition of euthyroid? Are they using a TSH value of less than 2.5? Have they used a TSH value of less than 4? So that the results are all over the place, and sometimes you need to go and dig out But the consensus is if a TSH is below 2.5, even if antibodies are positive, in general, most doctors would not recommend starting levothyroxine therapy. So when you come to euthyroid pregnant women with thyroid autoimmunity, it can be considered with TPO antibody positivity only if there is a history of pregnancy loss, recurrent pregnancy loss, or a bad obstetric history. And again, this is a grade 2B or a C recommendation. TPO antibody women with TSH less than 4 do not require treatment. Again, this is from the FOPSI guidelines. They also point out that this is a controversial statement and is at the discretion of the treating clinician. So I'm hoping I've not confused everybody too much. Overt hypothyroidism, always treat. So any TSH more than 10 or any TSH associated with a drop in the free T4, consider treatment always, because it has been shown to improve outcomes. Subclinical hypothyroidism, you subdivide it into 2 categories. TSH between any TSH above 4 or strongly positive antibodies or a very bad obstetric history, consider treatment. TSH between 2 to 4 with negative antibodies, no bad obstetric history, consider, and normal free T4, of course. I would monitor, I would repeat a TSH and consider treatment, particularly if the TSH is increasing. So this is where our clinical judgment and a nuanced decision-making comes to the fore. That was my last slide, and thank you, and happy to have a very spirited discussion. Thank you. Can you stop my screen share, please?
Yes, ma'am. You can stop sharing. And we will move on to the third topic.
Yeah, can you? Yeah, thank you.
Yes. Today, the final talk will be taken by Dr. Anjali Satya, ma'am. I think we are heading for a short break. We'll be back shortly.
Dr. Sana, can we continue? We're running late as it is. Sana? Can we go ahead, Anjali?
Yeah, can I start off?
I think so. Sendil, Krishna, can we start?
Yeah, madam, we'll start now. Just
Yeah.
Dr. Sana is joining. 1 minute.
Yes, ma'am. Now we move on to the third and the final talk for today. I request Sentinel to share that screen. The last talk will be given by Dr. Anjali Satya, ma'am. Ma'am is a senior consultant endocrinologist currently practicing at Vijay Health Center, Vijay Hospitals, Vadapalani, and also at Apollo Specialty Hospitals, Vanagram. Due to her academic inclination, she has an active interest in research and publications, with various articles being published in journals, and has also authored chapters for textbooks in the field of diabetes, endocrinology, and gynecology. The topic on which ma'am will be speaking today is thyroid dysfunction in high-risk infertility. The role of thyroid in maintaining fertility is well established, and also by the understanding of its role, we have understood that thyroid plays a role in infertility at many levels, with direct and indirect effect, starting from the follicle formation, maturation, to all stages of fertility. What is the approach for high risk infertility cases where thyroid dysfunction may be an important factor? And how do you manage that? These topics will be taken by ma'am today. I hand over to you, ma'am. Dr. Anjali, ma'am, you may.
Thank you, Dr. Sana. Can you see my screen?
Madam, yes, madam, yes.
Okay. Um,
Yes, ma'am. You can just click on the full screen option, ma'am. It's the slideshow view.
1 minute. So is it visible now?
Yes, ma'am.
Okay. So so at the outset, let me thank About Company for this opportunity. It was nice listening to the talks given by Dr. Krishna and Dr. Jayashree. My topic will be to discuss thyroid dysfunction in patients with infertility. Here also, like in pregnancy, we have certain gray areas where there is no strong consensus. But of late, some new data have come in and probably there's a change in approach. So normal thyroid function is very important to maintain normal reproduction. But what we need to know is this is not the only thing. There are several other factors which have a strong role in resulting in normal or pregnancy. So thyroid dysfunction is one of the factors, and probably we need to address this if we detect this in the couple. Now, thyroid hormone receptors are widely distributed. They can be called ubiquitous. They have been demonstrated, both thyroid receptors, the deiodinase enzyme, the thyroid hormone receptors in the trophoblastic tissue, in the oocyte, in the embryo, doubtfully in sperm, and also in the endometrium. So we can understand that probably there is a very strong role of thyroid hormones in all these sites, which have a causative role in causing infertility. Now, thyroid hormones are involved in almost all phases of reproduction. If you look at oocytes, as I already mentioned, the thyroid hormone receptors and transporters have been demonstrated on the oocyte surface. T3, in combination with FSH, it enhances the granulosa cell proliferation and also inhibits its apoptosis. And sperm hypothyroidism is very well known to cause effect on semen parameters, both in counts and motility, though we do not know the exact mechanisms by which they exert this effect. They also have a strong role to play in fertilization rates and embryogenesis. Endometrium, yes, because deiodinases and thyroid hormone receptors have been expressed even in the endometrium. So is there a strong role to play in implantation failure? I think we need to look at that. And placentation, where T3 increases the expression of matrix metalloproteinases, which have a very strong role to play in early placental extravillous trophoblast invasion. So if you look at the HPT and the HPO axis, there's a strong crosstalk. So what happens in hypothyroidism is it is well established that there is impaired LH response to the GnRH stimuli, which can lead to anovulation or ovulation problems. Hypothyroidism also leads to a feedback increase in high TRH, which is responsible for secondary hyperprolactinemia that can also cause luteal phase defects and anovulation. If you look at the SHBG levels in hypothyroidism, there is a fall in SHBG levels and also fall in androgen clearance, especially of androstenedione. And because of structural similarity of TSH to FSH, there is a pseudo feedback inhibition of the gonadotropins. So there are several mechanisms by which the thyroid axis interacts with the HPO axis, and needless to say, we need to correct if at all we find any dysregulation in the HPT axis. So the hormonal changes in thyroid disorders, what I need to highlight in this slide is patients with both thyrotoxicosis, whether men or women, and hypothyroidism, there is the essential difference is the effect on the SHBG levels and the response of the gonadotropins to GnRH stimulation. In patients with hypothyroidism, there is a fall in SHBG levels, therefore a fall in total thyroid thyroxine, whereas the free thyroid hormone levels and the free androgen levels go up. In thyrotoxicosis, the reverse is true. There is a high SHBG, so high total and reduction in free thyroid hormones. If you look at the gonadotropin response, the LH response to the GnRH stimulation is subdued in patients with hypothyroidism, whereas it is increased in hyperthyroidism. Now, how does it manifest into clinical symptoms? We'll come to that. If you look at menstrual disturbances in thyroid disorders, these are more often seen in women with hypothyroidism, whereas almost 60% of the women may show they can show menorrhagia, they can show irregular cycles, they may have even amenorrhea, secondary amenorrhea, and because of secondary hyperprolactinemia in these patients. Thyrotoxicosis in lesser number of women cause menstrual disturbances, and commonly what we see is oligomenorrhea, and sometimes they may become amenorrheic when the weight loss is extreme. If we look at the prevalence of hypothyroidism can be subclinical. As Dr. Jayashree rightly pointed out, the definition of subclinical hypothyroidism there has been no consensus on that. And so several studies have used different criteria. But what is seen is the prevalence is to the tune of 5 to 7%. Overt hypothyroidism is seen in 2.4 to 5%. Hyperthyroidism in still lesser individuals, number of individuals. And if you look at the presence of thyroid antibodies in the general population, roughly 5 to 10% of people are positive for thyroid autoimmunity. If you look at the subfertile population, subfertility is defined as failure to achieve clinical pregnancy after 12 months of unprotected sexual intercourse. And it is estimated to affect 8 to 12%. If you look at the factors responsible for subfertility, the female-related factors account for 35%, male factors exclusively 30%, 1/3 of them, and combined factors may be seen in 20%, and roughly 15% we don't know the cause. So they are known as unexplained subfertility. So that category is called unexplained, where the cause is unknown. If you look at the male factor, it may contribute to roughly 50%, isolated male factors as well as the combined etiology. So a significant number of these people, a male factor may be important. So let us take a simple case. Here the wife is 25 years old. She has hypothyroidism since 4 years on 75 miles thyroxine. Cycles have been irregular following marriage, according to her, because she gained weight. She was earlier diagnosed to have PCOS, and on earlier evaluation was found to have normal prolactin and GTT. She's very anxious to conceive because she was diagnosed to have PCOS earlier, and she had heard that infertility is very common, and her current TSH is 10. On history taking, she also revealed that she was not very regular with 75 mics of thyroxine. So the values have been pretty, off the mark. Her husband is 29 years old, so far not evaluated, but his main complaints has been erectile dysfunction, which he has not reported to anyone. Weight gain is recent, sedentary lifestyle, no family history of autoimmune thyroid disease, is a non-smoker, teetotaler. But his semen analysis revealed that he had oligoasthenoteratozoospermia. He's an IT professional doing night shifts. Now the question is, whom should we screen for thyroid disorders? Now, because the prevalence of autoimmune thyroid disease is extremely high in women of reproductive age group, the current recommendation is that all women who report for subfertility must be screened for thyroid dysfunction. Regarding men, the same statement will not hold true, because what they say is that you need to screen only those men who have either erectile dysfunction, or they have ejaculatory dysfunction, or thirdly, if they have abnormal semen parameters. So only if you have these three should we need to evaluate them for thyroid dysfunction. Should we screen for autoimmunity in all? Women who report for subfertility, yes, but a generalized screening for all women who are planning pregnancy, this may not be indicated. What is the ideal TSH prior to ART? In a woman who is already hypothyroid, like in our patient, we have to make sure she said she has been irregular, so we have to counsel her that she must be regular with her medication, and her ideal TSH should be brought below 2.5 before she plans conception. And once she gets pregnant, she needs to follow it up in pregnancy, as there may be an increment, or she may need to hike up her dose as the TSH goes up. So that needs to be monitored once she conceives. So overt hypothyroidism, there is no debate. It's well known, and definitely if we treat it, many of these factors could be reversible. Women who are anovulatory may just become ovulatory. But again, the data is not very robust. What they say is that if you have hypothyroidism, hypothyroidism can lead to these factors which I had mentioned earlier, and menstrual irregularities also may normalize on thyroid hormone replacement. Men with these three categories, erectile dysfunction, ejaculatory dysfunction, and abnormal semen parameters, we need to offer them thyroxine therapy if they are diagnosed to have hypothyroidism. But the data is lacking in subclinical hypothyroidism. So now we come to the subclinical hypothyroidism in female fertility. Now, the studies which were conducted earlier in before 2017 or 15, they were looking at cutoffs which were about 2.5, and many studies have looked at cutoffs above 4. So the definition of subclinical hypothyroidism has been variable because there has not been a clear-cut consensus on what should be the upper limit range for the TSH to define this state. So what was observed in most of these studies was the adverse fertility outcomes seemed to surface once the TSH started climbing up above 3.5. And most of the studies, it was well seen above 4. And treatment in this category of patient, as Dr. Jayashree pointed out, even as for pregnancy, whether they are thyroid antibody positive or negative, there was some definite benefits were seen as regarding pregnancy rates and fertilization rates and even live growth rates. To date, there are no randomized controlled trials to evaluate the benefit of thyroxine on spontaneous pregnancy rates in women with subclinical hypo or women who are antibody positive. So probably there may be no indication. Now the current consensus or the newer guidelines which were published by the European Thyroid Association have said that euthyroid antibody positive women do not treat, but just follow them up. Among subfertile women with TAI, that is presence of thyroid antibodies, a meta-analysis of 3 randomized controlled trials showed that that used TSH above 4, they found a beneficial effect. So what is seen here is women with subclinical hypothyroidism with a TSH above 4, benefits may be seen. But those between 2.5 to 4, again, it is a very fluidish thing. And currently, there is no agreement on treating these women. So if you look at risk of infertility associated with autoimmune thyroid disease, the studies which were done from 75 to 2004, when you looked at the pool data, definitely it was seen that thyroid antibodies were associated with unexplained subfertility in even euthyroid patients. If you look at the numbers, 10% of these women may be positive for thyroid antibodies, and most of these studies have actually looked at thyroid peroxidase antibodies. Some of these studies have also looked at thyroglobulin antibodies. So these women who are said to have positive thyroid autoimmune immunity are characterized by increased levels of TPO antibody, and they may be either euthyroid or they may have subclinical or overt hypothyroidism. But what we need to understand is these women, when we see them before pregnancy or when they are trying for fertility treatment, the chance or the risk for this subclinical hypo to progress into overt hypothyroidism is much higher. So they need to be followed up during pregnancy. Now, thyroid autoimmunity may not be the sole factor which is responsible for adverse outcomes. It may just reflect a generalized immune dysregulation. This was well discussed in the previous talk. So this may not be the sole cause for implantation failure. So if we identify this, this could be just one of the reasons, but we cannot say this per se is responsible for implantation failure. We have also seen in studies that TPO is expressed in the endometrium and even placenta, and probably this can explain the high frequency of miscarriage and implantation failure. If you look at thyroid autoimmunity, this is screened in 3 subgroups of women who report for fertility. One is women with PCOS who come for subfertility. 2, those women who have a diminished ovarian reserve as characterized by low AMH levels or higher FSH levels on day 2, or women who are already documented to have a primary ovarian insufficiency. 3rd is the women who belong to the unexplained subfertility. These 3 groups of women should be screened for thyroid autoimmunity when they report for subfertility treatment. But other women who have only male factor positive, or if they have tubal factors, thyroid autoimmunity may not have any role in that. In PCOS, it's also said that polymorphisms of the PCOS-related gene for fibrillin-3 can alter the effective of the TGF-beta, which is a regulator of immune tolerance, and also a higher estrogenic state may contribute to autoimmunity in this women. So the possible mechanism of autoimmune thyroid disease causing infertility could be actually an alteration in the natural killer cell concentration, but there may not be a significant difference in the cytotoxic activity. And what they say is the presence of antibodies and an elevated TSH may increase or step up the IL-2 production. And this cytokine-mediated NK cell activation could be responsible for reproductive failures and miscarriages. So the first meta-analysis was published in 2013. I thought I would just highlight the years. And this looked at levothyroxine treatment and pregnancy outcome in women with subclinical hypothyroidism undergoing ART technologies. And this meta-analysis had come out with certain conclusions. One was the meta-analysis of thyroid antibodies and miscarriage risk. And the 19 cohort studies were taken, and there was a clear-cut association between positive thyroid antibodies and a higher prevalence of miscarriages. And when they were treated, effect of treatment with thyroxine and thyroid autoimmunity and its effect on reduction of miscarriage and preterm delivery was well seen when women with thyroid antibody positive, the green box, when they were treated with thyroxine, there was a definite reduction in miscarriage rates and preterm delivery rates compared to women who were TPO antibody positive but were not treated. So now we go to the next section called hyperthyroidism, which I said constitutes only 0.5 to 1% of women who present with this. In women, hyperthyroidism may lead to oligomenorrhea, but generally the cycles are regular, may become amenorrheic if there is extreme weight loss. They have higher SHBG, same with men, and higher estradiol levels. In men, these estradiol levels can lead to gynecomastia. Women with hyperthyroidism, especially Graves' disease, it's very important that they should be rendered euthyroid, and the euthyroid state should be maintained for several months before they actually plan pregnancy, because if untreated, it can lead to early pregnancy loss. In men, hyperthyroidism, because of the high estrogen levels, leads to impaired libido, erectile dysfunction, premature ejaculation. Abnormal semen parameters have been well documented. So the current recommendation by the Eurothyroid Association, which was published recently, they said that do not postpone the ART treatment in case of subclinical or overt hypo or hyperthyroidism in the male, as long as the sperm parameters are not severely affected. So you can actually go ahead with the treatment and treat them at the same time. The second case is a young lady married for 3 years, anxious to conceive. Her cycles were regular in the past, now irregular since 2 years, and for last 3 months, amenorrheic. Her husband was also evaluated and no male factors were identified. When she was evaluated for her amenorrhea, she was found to have elevated FSH of 36, prolactin, which was normal. Her anti-Mullerian hormone level, which is a marker of ovarian reserve, was found to be quite low. Ultrasound showed a very thinned out endometrium, which means she was actually having a hypoestrogenic state. And she was screened for thyroid and was found to have a TSH of 3.6, but the antibody levels were quite high. She also had a family history of autoimmune thyroid disease. So here is a woman who has probably ongoing ovarian dysfunction, and her follicle count has not been mentioned here, and probably we can, that would document whether she has any ovarian reserve at all. So what are the effects of thyroid dysregulation on ovarian reserve, fertilization, and embryo development? Primary ovarian insufficiency is defined as loss of ovarian function before the age of 40. And as the age advances, we find that it is highly prevalent, 1 in 100 by age 40. So causes could be genetic, autoimmune, which would involve thyroid autoimmunity as one of the causes. There could be iatrogenic factors and idiopathic factors. So in all women who present with primary ovarian insufficiency or diminished ovarian reserve, where the FSH may be normal, but the AMH levels are rock bottom, we need to screen all these women for thyroid autoimmunity, because as it is one of the causes for ovarian insufficiency. There were several studies here, and they found that this was a retrospective evaluation in 2,000 odd Chinese women. who were initiating ART, they found that lower AMH concentrations and antral follicle counts and higher FSH were seen in women aged above 35 years. So the factor here is those women who are older, above the age of 30 to 35 years, are definitely expected to show a lower AMH counts when they have an associated autoimmunity or thyroid autoimmunity or subclinical hypothyroidism. A similar large cross-section study in Chinese, where over 1,044 patients were studied. Again, women with diminished ovarian reserve demonstrated higher percentages of antibodies when compared to counterparts with normal. So, screen subfertile women with unexplained subfertility or those above the age of 35 years for thyroid dysfunction and autoimmunity. And those women, I said, who have a value above 4, there is no disagreement. Treat all of them, whether they are antibody positive or negative. But those women who have a value between 2.5 to 4 antibody positive, here we choose them to treat on a case-to-case basis. Again, we have to use a clinical judgment. There are certain indications where we would like to treat these group of women, where they are called euthyroid autoimmunity, which I'll come to later in the next slides. Now, what is the effect of thyroid disorder on oocyte retrieval rate, fertilization rate, and embryo quality? Now, one of the major outcomes or in vitro outcomes of an ART procedure is the oocyte retrieval. That will tell how many, what is the ovarian reserve of that woman. In the meta-analysis by Busnelli, TAI was not associated with any reduction in oocyte retrieval. And these data were confirmed in a recent study also, which was published. So most of the studies have now shown that thyroid autoimmunity may not have any effect on the oocyte retrieval rate, whereas age has a greater bearing in these women. Regarding fertilization rates, they were again found to be 63% in women with TAI and 72%. Hardly, it was slightly lower in these women, but it was not significantly low. Antibodies have been documented in follicular fluid of all subfertile patients with thyroid autoimmunity. Also, some of these studies, this was studied actually in mice. In mouse models, they have documented presence of thyroid antibodies on the surface of pre-implantation embryos, which can bind to the antigens expressed in the zona pellucida. So is it that the embryos themselves express the antibodies? We are not sure. That interacts with antigens expressed in the zona pellucida, impairing the fertilization rate. And so, is ICSI more successful than IVF because the antibodies on the surface are taken care of? So here we are not sure, and I think a conclusion cannot be got, and more studies are required. Poppy et al., who has got most of the studies to his credit in fertility and thyroid autoimmunity, he performed recently a meta-analysis on ART outcomes in women with and without TAI who exclusively underwent ICSI. IVF is a condition where you just allow the gametes to meet in a culture media. ICSI is actually probably, there is a 1% risk in IVF that, 1% chance of failure where there could be acrosome defects or the cap defects where the sperm is not able to pierce. That can be sort of, overpowered when we use ICSI as a method of IVF. And now most of the centers use ICSI for male factors. So fertilization rates from TAI positive and TAI negative were comparable when ICSI was used as a method of IVF. And comparable miscarriage rates were also observed, suggesting that ICSI may actually overcome the impeding effects of antibodies on the oocytes and embryos. But this is again just a hypothesis, not proven. So can we offer ICSI for women with evidence of TAI? I think we cannot make a statement here, but studies are coming and we need more and more data on this, whether there is expression of thyroid antibodies on the embryo. Regarding embryo quality, again, recent papers published have shown no impact of thyroid disorders, either presence of antibodies or subclinical hypothyroidism on embryo quality. So embryo quality, fertilization rates, and oocyte retrieval rates, there is no, they are not affected by thyroid autoimmunity. So this, again, this is data on embryo quality. So the recommendation is that you try to treat women with TSH levels above 4, where you don't have data for your population, use the upper limit of the normal range and try to keep the TSH less than 2.5. So what is the alteration in thyroid function in IVF? or controlled ovarian stimulation. Now, in IVF, COS or controlled ovarian stimulation is an integral part. What happens is you give initially GnRH antagonists or GnRH analogs to cause pituitary downregulation. After it is well downregulated, then the stimulation starts with gonadotropins till the oocytes number reach, and the ovarian stimulation induces a very rapid and supraphysiologic increase in serum E2. And that can reach values as high as 4,000 to 6,000 nanogram per liter, which may mimic second trimester of pregnancy. So this high increase in E2 during ovarian stimulation can increase the TBG production and sialylation by the liver, leading to reduced clearance of TBG. So TBG stays in the circulation, and ultimately there's a fall in free thyroid hormones. And this fall in free thyroid hormone steps up the TSH levels. There could also be a direct effect of the high E2 elevation during this controlled stimulation on TRH, and that also leads to increase in TSH. So this TSH level increase is expected whenever women go in for a controlled ovarian stimulation. And the elevation in TSH caused by this stimulation can last for almost like 1 to 3 months. So what they found is women who are already hypothyroid on thyroxine, when they go for controlled ovarian stimulation, the TSH increase is more pronounced. Similarly, this may be more pronounced in women with autoimmunity, that is presence of thyroid antibodies. So during OS, the patients with positive antibodies, due to they have a reduced thyroid function reserve, and high ovarian stimulation is a high demand for the thyroid gland. They show increased TSH values and decreased FT4 levels. And hence, it's very important that women who are hypothyroid, it's better to make sure they're euthyroid for a considerable period of time before they undergo controlled ovarian stimulation. OHSS or ovarian hyperstimulation is hardly seen these days because of higher usage of GnRH antagonists for downregulation. But again, in OHSS, the estrogen levels are very high, as seen in controlled ovarian stimulation, can lead to thyroid hormone variation. So you can expect a TSH to go up when the woman undergoes ovarian stimulation with gonadotropins, and the effect can last for almost like 1 to 3 months. Now, what happens to once the oocytes are developed, there's a single HCG given to trigger. And this function, what happens when you give a HCG trigger? HCG has a structural similarity to TSH. So we expect a fall in TSH as is seen in the first trimester of pregnancy. This fall of TSH following an HCG trigger is seen in healthy patients. But those women who have thyroid autoimmunity, they show a blunted TSH and T4 response. So they don't show a TSH fall following an HCG. This has been documented in studies where they have looked at TSH levels following HCG trigger. So the recent recommendations by the Europe Thyroid Association, which was published in 2021, this was authored by Poppy et al. They said that you check TSH well before OS, make sure before women undergo controlled ovarian stimulation, make sure they are euthyroid and maintain a TSH less than 2.5. TAI positive women with TSH above 2.5 and less than 4 should be only treated by a case-to-case basis, which I mentioned 3 factors. Which are the cases which indicate? So if women have a TSH of 2.5 to 5 and they have thyroid autoimmunity, we would choose those women for treatment, those who have had previous IVF failures, who are older, more than 35 years, who have very strong antibody titers, more in thousands, if they had a bad obstetric history, recurrent miscarriages in the past. And so these are certain factors where we would consider giving them a low dose of thyroxine. But otherwise, euthyroid, autoimmune, positive thyroid autoimmunity, we can actually follow them up once they conceive. So this is the next slide, which says the same thing. There were studies, 2 studies, which had come recently. One was a Chinese study looking at 600 cases undergoing ART and 952 British cases who were either on subfertility treatment or not. And both these studies, thyroxine did not reduce miscarriage rates or it did not increase live birth rates in euthyroid women with positive thyroid antibodies. That is, these were the women with TSH between 2.5 to 4. So if you look at the IVF or ICSI outcomes in women with thyroid disorders, now question is, can treatment with thyroxine improve ART outcome? most of the data or most of the studies have shown that there's hardly any difference in ART outcomes in women who have a TSH less than 2.5 or those women who have a TSH between 2.5 to 4. But definite improvement or benefits were seen in women who had TSH levels in the upper limit, more crossing 4. And these two studies, which looked at a cutoff of 4.2 and 4.8, values less than that, the thyroxine treatment had no effect, but values above 4, we have had definite benefit. So majority of data on the subclinical hypothyroidism, the ART outcomes suggest that there is no association with lower birth weights and higher miscarriage rates compared to TSH less than 2.5. That is absolutely normal thyroid function. So the earlier studies where the meta-analysis were, the 2013 was published, they looked at studies by Negro et al. He had looked at TSH less than 4.2 before ART and definite benefits were seen. Those who had looked at no benefits were seen, and in TSH above 4 and above 4.5, when they were treated with thyroxine, the risk ratio for, they showed a very higher delivery rates. So the meta-analysis provides evidence that thyroxine supplementation should be recommended to improve clinical pregnancy outcome in women with subclinical hypothyroidism with values above 4. Those women who have values 2.5 to 4, we would decide on a case-to-case basis. So I think this is a repetition of what I said. The ATA 2017 guidelines had mentioned this, that thyroxine may be considered in euthyroid antibody positive. They had made a statement with saying that there is low evidence. And now in the current ETA, they say that probably we should not offer treatment to this category of women who have lower TSH and though they may be positive for thyroid antibodies. The second meta-analysis came in 2018. Which again had the only randomized control trial here was by a person called Wang in 2017. He also documented no benefit of thyroxine replacement in improving fertilization IVF outcomes following ICSI. But it did say that there is a potential to reduce miscarriage rates, though it is not overtly seen. Thyroxine supplementation may be recommended. So that is why when we consider women with a bad obstetric history or recurrent miscarriages in the past, probably the clinician may take a judgment to treat these women. So the case 3, I think this is not a very common case, but I thought I should discuss radioactive iodine therapy. This is a young lady because thyroid cancers or differentiated thyroid carcinoma is seen in young women. So she's a 29-year-old lady diagnosed to have papillary carcinoma thyroid. 3 years ago, she had lymph node mets, then given single dose of high dose radioactive iodine, following which her whole body scans have remained negative and thyroglobulins undetectable. She had a surgery 3 years ago. Now her cycles are regular. She got married 8 months ago, but she is very anxious to conceive, given her history. Her husband has been evaluated and found to be normal. Now, what is the effect of radioactive iodine therapy on fertility? I think most of the studies that have looked at larger numbers have looked at patients who have had high dose radioactive iodine therapy for differentiated thyroid cancers. I did not mention when I discussed hyperthyroid patients that we do offer radioactive iodine therapy for women with Graves' disease. There we do advise them not to plan pregnancy for the next 6 months or even better for 12 months. But here, the dosage used for thyroid ablation is to the tune of 5 to 15 MCI. And the effects on folliculogenesis and even in men, the effect on germinal epithelium has not been significant. So not much effect is seen when low dose radioactive iodine used for Graves' disease, but we do tell them not to plan pregnancy for 6 months, better for 1 year. Now, when we look at women who have had very high dose radioactive iodine ablation for differentiated thyroid cancer, a definite negative impact is seen on ovarian reserve. So there was a Dutch study which had looked at 65 women, young women, where the AMH levels, which is a marker of ovarian reserve levels, significantly declined during the first 12 months following the ablation therapy, but it stabilized thereafter in those women who got ablated with a single dose. But sometimes when they have lung metastasis or peripheral significant or large tumor size, they may require multiple doses of radioactive iodine. A further decline was demonstrated where they required multiple doses. This was well documented in several studies. And the steepest decrease in this ovarian reserve was seen in those women who are older, 35 years and above. So that is why I think these results will definitely support a less aggressive treatment with radioactive iodine. Now, the current guidelines, ATA guidelines also mention that probably we should approach a less aggressive approach in differentiated thyroid cancer, which has a relatively very good prognosis, especially in women who are older than 35 years with a desire to have a child. So I think our decision there to treat differentiated thyroid cancer should be a different one. Regarding men, radioactive iodine can temporarily increase FSH. It decreases inhibin B and also has a negative impact on sperm parameters. This can be seen almost up to 13 months. So an increase in sperm chromosomal abnormalities, aneuploidies were documented at 3 months and even 13 months following radioactive iodine ablation. So these men who take RAI for differentiated cancer are normally advised to postpone their fertility treatment now for 120 days. But since these aneuploidies have been documented even as long as 1 year, I think we should be cautious and probably advise them to take 1 year off. So whether RAI treatment for well-differentiated cancers was related to lower birth rates in a large US registry base of 18,000 women, while comparable birth rates were observed in the whole cohort, women aged 35 to 39 years, who I mentioned earlier, they suffer the most. The ovarian reserve falls very fast. They experienced a 29% reduction in live births after RAI. So it is the age of the woman who actually that determines the response to the RAI treatment. Time to live birth was also prolonged in these women who are older. So again, when a woman comes to us for a differentiated thyroid carcinoma, RAI treatment should not be delayed for fertility reasons. We can always delay the pregnancy. But women who are especially older, more than 35 years, should be told about the impact of RAI on their future risk and the risk on live birth rates, because AMH has been documented. And so they should have an AMH probably documented even before radioactive iodine therapy is given. So summarizing, autoimmune thyroid disease is very common in reproductive age group. Hypothyroidism and hyperthyroidism both can have adverse effect. The available data from different associations like the American Thyroid Association, ETA, the Reproductive Medicine Society, they support the routine measurement of TSH in all subfertile women who attempt pregnancy. But we don't need to check thyroid antibody levels in all. But probably if the TSH is above 2.5 and you need to decide whether to follow them up in pregnancy, probably is going to be useful. So screen all women for thyroid dysfunction, men, only those men who have ejaculatory erectile dysfunction or abnormal semen parameters for thyroid abnormality. The presence of antibodies helps us to sort of assess the risk. They may identify women at risk for developing hypothyroidism following controlled ovarian stimulation. So those women who are positive for antibodies, probably we should follow up the TSH 2 weeks after the stimulation starts and see whether the TSH goes up and adjust the dose of thyroxine accordingly. And also during gestation, we need to watch them every 4 weeks during the first and the second trimester. So this could also be a predictive marker for their risk for developing postpartum thyroiditis after delivery. Euthyroid subfertile women, according to the current meta-analysis, they say that there is no beneficial effect of thyroxine on pregnancy outcomes, so we can wait and watch. So systematic treatment of all euthyroid women with antibodies should not be recommended. Probably on a case-to-case basis, as I mentioned, if they have a diminished ovarian reserve or they have a high FSH and low AMH, older age, history of recurrent miscarriages, recurrent IVF attempts, and high levels of thyroid antibodies, then probably we could consider a low-dose therapy where we can use 25 to 50 micrograms of thyroxine. The benefit may not be great, but it won't harm the patient. So with that, I'll conclude my talk and I'm happy to take the questions.
Yes, thank you, ma'am. Now I open the session for questions. The participants, for all the 3 talks, any queries or doubts, please do type in the chat box. Yes. For the first topic that we had today, approaching hyperprolactinemia by Dr. Sheshadri sir. So you've spoken about hyperprolactinemia in the various other contexts. So what is the relationship between PCOS and hyperprolactinemia?
Remember that about 15 to 16% of patients with PCOS will have prolactin excess, usually less than 50. The second bit is that PCOS, that hyperprolactinemia is itself a case where you can have POA, that is polycystic appearing ovaries, right? There has been no data to suggest that treating this mild hyperprolactinemia in PCOS either affects or improves fertility rates, but generally when people do see prolactin excess in patients with PCOS, irrespective, I guess, our gut is to treat simply because anyone with infertility you treat. It's also not very clear if, and I haven't seen data saying that if you lower the weight in women with PCOS or if ovulation is restored, that this prolactin sort of drops down. An interesting project to look at. But up to 15% of women with PCOS will have hyperprolactinemia, not associated with the pituitary loss.
Thank you, sir. Dr. Jayashree, ma'am. Ma'am, for managing a patient with elevated TSH during pregnancy, how would you recommend a physician proceed with dose adjustment or titration from first trimester to second and delivery and then postpartum immediately? How should the dose be adjusted accordingly?
Yeah, sorry about that. So I was saying the recommendation is to start with 1.6 to 2 microgram per kg per day dosage. I think most of us practically use a more sort of, I would say, a pragmatic approach depending on the actual TSH values. And if it's a borderline elevation of TSH 4 or 5, you would start with 25 or 50 mcg. If it's a heavier woman, you start with a 50 microgram. If the TSH is about 10, I think in pregnancy, most often, particularly if the BMI is in the higher range, you go ahead and get started with 100 micrograms. And repeat the TSH again within about 4 to 6 weeks, depending on, try to maintain the TSH below 2.5. And of course, make sure that you do all the other usual precautions. So the thyroid tablet is being taken on an empty stomach, that all of the vitamins are being taken after lunch and dinner, that she's not throwing up immediately upon taking the thyroid tablet. If she's having severe hyperemesis of pregnancy, she can take the thyroid tablet a little bit later for some part of the pregnancy. And once the nausea and vomiting has settled, she can go back to early morning empty stomach. So these are all some of the practical things that we use. And keep adjusting the thyroid in increments of somewhere between 12.5, 25, depending on how much the TSH is thing and how much weight gain is occurring. So typically you tell them that you are going to require higher doses as you gain weight and the baby gains weight. After pregnancy, I usually go back to the pre-pregnancy dose if they've been on thyroid tablets and she had a normal TSH pre-pregnancy. So go back to the pre-pregnancy dose. I say to reduce the dose the day after delivery. The guidelines recommend waiting for 2 weeks. I think it's just easier. Otherwise, women tend to forget. So the day after delivery, just go back to the pre-pregnancy dose. And if they have not been on thyroid tablet before pregnancy, reduce it by at least a third. So if they were on 100 mcg at the time of delivery, reduce it to 75 or maybe even 50 after delivery. And repeat the thyroid blood test 2 months after delivery.
Thank you, ma'am. It was very well elaborated. Dr. Anjali, ma'am, regarding infertility in high-risk cases, ma'am, what is the link or relation between hyperthyroidism and the presence of infertility in your experience, ma'am?
The prevalence of hyperthyroidism compared to hypo is definitely lesser. And what we find in clinical practice is if they are the thyrotoxicosis is very severe, then there is a high likelihood of early pregnancy loss. So we always tell them that they must be rendered euthyroid, and the euthyroid state should be maintained for at least few months before they plan conception. Again, we need to decide if they have had a radioactive iodine ablation, as I mentioned, they need to give a 1 year break, 6 months definitely, and preferably 12 months before they plan pregnancy. So thyrotoxicosis we don't see very commonly. In men, it can cause erectile dysfunction, It can cause fall in libido and also abnormal semen parameters. So when we look at a subfertile couple, we are not focusing on the woman. We need to identify what's happening the other side. So extreme weight loss can render a woman amenorrheic, but that is generally because they report earlier. So we are able to detect them earlier and start them on therapy. So we always tell them that the thyroid, also hyperthyroidism, when we follow them up in pregnancy, we need to make a choice. We need to make a shift of antithyroid drugs to propylthiouracil if they are on a high dose. If they are requiring very minimal dose of neomercazole or carbimazole, we can actually stop once they conceive for the first trimester, because to avoid teratogenic effects, possible teratogenic effects. One more thing I wanted to mention in my presentation is that we have been talking about thyroid autoimmunity, but I think the impression should not be that this is the only factor, which is, it could be one of the factors, may not be truly responsible, but recently a study had come which had looked at selected embryos where embryonic biopsy was done. Only single embryo transfers were done for women with subfertility. These aneuploidy was ruled out by embryonic biopsy. And when you have a good quality embryo, they could achieve 90% pregnancy rates. So this was a study published in Human Reproduction. So ultimately speaking, all these factors which are there, or thyroid autoimmunity, presence of other auto, APLA, whatever, if it's the embryo which actually is the predominant factor which gives positive effects. So if you have a good quality embryo, free of chromosome defects, the implantation rates are close to 90%.
Yes, thank you, ma'am. Dr. Seshadri, as of now, there are no questions in the chat box. So I would request all the speakers to conclude briefly, and then we can proceed with the vote of thanks. So I hand over to first Krishna Seshadri sir to give a brief conclusory note for today's talk.
Krishna, you're on mute. You're on mute again, Krishna.
Right. It's not easy to shut me up. Anyway, so thanks. I think we had a great time. Listening to all these talks. It's very interesting. The question has always been whether this is whether the thyroid is just a syndrome that goes along with infertility, or is it just that there is something deeper to it? I think we will never answer in our lifetime, and I hope we don't, because then it takes away a lot of fun from investigation and research over the years. Similarly with prolactin, I think what has happened is that because the therapy is for both thyroid and prolactin has remained the same for so many years, our interest in the research in these topics is very low. But I think there are so many exciting things that are happening out there that will help us in the future. For example, for the infertility, but a lot of work on the spindle counts are there that makes a lot more sense. So I will leave it here and let the two ladies take over from here. And thank you so much for having me as part of this program. I thoroughly enjoyed it. Shri, Anjali.
Yeah. Again, I enjoyed it a lot, listening to both of you. And I think what struck me is really drives home the point again that endocrinology is an extremely, what do I call it, a nuanced clinical specialty. I don't know if I'm getting the right word, but you can't just go by the numbers. The numbers don't make the diagnosis. So, the clinical situation, what's happening with the patient at that point in time, I think that is necessary for us to make decisions regarding treatment. So that's why I think we all enjoy endocrinology. Over to you, Anjali.
I think I also enjoyed these sessions because, as you rightly said, we have to look at the whole picture. What we are describing as a thyroid dysfunction is very common and highly prevalent in the population. So I think as a physician, we try to apply all sorts of find out, because these are subfertile couples are a sort of a vulnerable population. They're desperate to get a pregnancy. The doctor who treats them also is desperate. So they try to find out all possible abnormal factors. Several of these are unknown to us. So we seek evidence, and evidence is also sort of contradictory. There are several gray areas, and I think we really need to get more and more research into that area, have clear ideas. But till that, I think we should use clinical judgment, as you said. Look at all possible things where we can help them and achieve a positive outcome.
Till COVID came by, infertility was the area where emotion-based medicine was running rife. But then COVID showed us where emotion-based medicine becomes very, very big, isn't it? Yeah, that's true. It's hard to argue with a person. We have patients who have, it's 4.2 better than 3.9, and with two different lab values, one from a SIBA counter, another from another. But that's the nuance, and that's the fun. Yeah, great, absolutely. Sana, you can take it home. I think
Yes.
people are hungry.
Yeah. So I would like to conclude the session with the vote of thanks. On behalf of FAPET, I extend my warm gratitude to our speakers, Dr. Krishna Sheshadri sir, Dr. Jayashree Gopal ma'am, and Dr. Anjali ma'am, who have taken 3 topics slightly different but all interrelated, as they all affect women's health in a substantial way. The discussion was enlightening, informative, and has definitely enriched all the participants who have joined today. I thank all of you for being a part of our discussion today, and I request all of you to kindly log off now. We wish you uh, a good day and also good evening.
Good evening and good night.
Good night.
Bye, everyone.
Thank you, madam. Thank you, madam.
Bye.
Deepa.